Hey, healthcare friends, do you dread doing your notes every day? Do you feel like you can never get ahead of charting? If you're shaking your head yes, keep listening. Freed AI is a medical scribe on a mission to free clinicians everywhere. Freed AI listens, transcribes, and writes medical documentation for you, written in your style and ready the moment the visit is over. All you have to do is give it to your patient. Just imagine leaving the office at the same time as your last patient. Freed is HIPAA compliant, secure, and takes less than 30 seconds to learn. Artificial intelligence cannot replace you, but it can do the administrative work that no human should be subjected to. Get back to doing what you love, helping your patients, and let Freed AI do the rest. Hey all, welcome back to the Real Life Pharmacology Podcast. I'm your host, pharmacist Eric Christensen. Today we've got drugs 56 through 60 of the top 200 medications. Keep it on here. Let's get into it. So let's look at Nitrofurantoin. Brand name of this medication is macrodantin or macrobid. Mechanistically, this drug is altered by bacterial flavoproteins and form reactive metabolites that disable ribosomal proteins and other molecules within bacteria. One of the most important things is UTIs is fairly common. This is what this medication is used for. UTIs are fairly common in geriatric patients, unfortunately. But we need to pay attention to renal function with this medication. If renal function is too poor, this medication will not work and potentially can cause some toxicity issues as well there. So there is some evidence, package insert, I believe, says do not use less than 50 to 60 mils per minute. Don't quote me on that 100%. But as that creatinine clearance, as that renal function declines, we got to get a little bit more careful with this medication, like I mentioned. There is some evidence that says possibly down to 30 mils per minute, it may be acceptable to use this medication. But I would say most clinicians agree that less than 30 mils per minute, nitrofurantoin absolutely should not be used. So again, kind of in that 30 to 60 mil range. It's kind of a risk versus benefit assessment, and we do have some evidence under that 50 to 60 mils per minute range. But anything less than 30 mils per minute generally is a contraindication to the use of nitrofurantoin. Adverse effects, so there's kind of a nuisance, maybe scary adverse effect to patients, or alarming. It can change the color of the urine, and usually this isn't anything significant, but patients can feel like their infection is maybe getting worse or something to that nature. So definitely a good thing to educate patients about, that it may change the urine color to a brownish or orange. All right, now we've got some of those rare adverse effects. Not incredibly common, but again, more common in older patients as well as those with worsening renal function. So CNS changes can happen, neuropathy can happen, and there's also some risk for pulmonary toxicity, respiratory distress. Again, these are typically pretty rare, but they definitely do need to have your attention, particularly in older patients or patients with maybe borderline renal function there. All right, moving on, let's talk about the top clinical pearls for fentanyl patches. Brand name for fentanyl patch is Duragesic. This is an opioid agonist, similar to your morphines, your oxycodones. So by stimulating mu receptors in the central nervous system, we get that analgesic relief. Now with fentanyl patches, it takes some time for that drug to get across the skin. So when we place a fentanyl patch, it's going to take usually hours for that analgesic relief. And so that it makes sense that fentanyl patches are not supposed to be used for acute pain. Okay, so important definitely to remember that versus a PRN oxycodone immediate release pill that can work quickly or relatively quickly to help with pain. Any obviously sort of injection with an IV or IM opioid like morphine, for example, that's going to work quickly to relieve acute pain. Fentanyl patches do not work that way. Okay, so important to recognize that. Question I often have been asked is, can you cover a patch? Can you tape it on there with another adhesive? Tegaderm has typically been used to help keep fentanyl patches on a patient if there has been an issue with that. Remember that you cannot heat or use a heating pad over top of a fentanyl patch. That'll actually increase the rate of absorption, accelerate the rate of absorption, and potentially increase the risk for higher concentrations and toxicity. Adverse effects, so class effects of opioids. Fentanyl is really going to be no different. Fentanyl patches are really going to be no different here. Constipation, nausea, and vomiting can happen with fentanyl patches. Obviously, sedation, CNS depressant action can certainly happen. Confusion can happen with the use of opioids like fentanyl, of course. And then typically in overdose or as doses escalate, we run into the risk for respiratory depression and excessive sedation. Now with opioids, there's no ceiling dose due to tolerance. So over time, a patient's tolerance typically develops. And of course, it is a Schedule II controlled substance. We've got risk for addiction and dependence. Where I've seen, fentanyl patches probably used most often are hospice type situations. Obviously we probably don't worry about addiction and dependence quite as much, in end of life type situations. And then of course drug diversion. I've seen fentanyl patches stolen off of patients. So we've really got to be aware of that, pay attention to that. And if patients are complaining, concerned about increases in pain, that's a good thing to double check to ensure that they're actually getting their fentanyl patch, that it's still on them. Maybe in patients that are displaying some more pain, maybe they aren't cognitively as intact in the patient population we're using this on. So again, things you can kind of look out for and pay attention to there. All right, moving on. Next medication. We've got a nitrate medication, Isosorbide mononitrate. Brand name of this medication is Imdur. And this medication is used primarily for the prevention of angina-type symptoms. Mechanistically, how does it work? It's a direct-acting vasodilation on the vessels by nitric oxide, which causes smooth muscle relaxation and ultimately a reduction in blood pressure and kind of improving that blood flow. Adverse effect profile, in my experience, the most common issue I've heard reported is headaches. Patients will sometimes report this adverse effect. Obviously, if we drop blood pressure too far, orthostatic hypotension, dizziness, things along those lines can happen as well. As far as monitoring, it's probably what you would expect. We're going to monitor blood pressure with this medication. Pulse should also be monitored as well. Nitrate tolerance. So this is something I wanted to discuss a little bit. So kind of similar to opioids, I guess. Patients can develop some tolerance to this medication where it doesn't work as well as it should if we're using it too frequently. So nitrate tolerance can start to develop within 8 to 12 hours of kind of overuse or frequent use. So that nitrate free period is ideal, and utilizing the once daily isosorbide mononitrate is what we're typically going to utilize here. All right, one really, really important drug interaction. It's going to show up on pharmacology exams, board exams for sure. This medication, isosorbide mononitrate, should be avoided with the use of PDE5 inhibitors. So recall that PDE5 inhibitors are primarily used for erectile dysfunction. That's a drug like tadalafil, sildenafil. This interaction can lead to profound hypotension and dizziness. So, and obviously increase the risk for falls and significant cardiovascular kind of collapse almost, where the blood pressure drops so much. So pay attention to that, educate patients to that with those patients that are utilizing PDE5 inhibitors. All right, moving on, we've got number 59, and that is fluoxetine. Brand name of this medication is Prozac. This is an SSRI. So by inhibiting serotonin reuptake, it ultimately increases serotonin in the synapse and helps to improve mood and depression. A few important educational points here regarding fluoxetine use. So first off, from a patient standpoint, recall that pretty much all antidepressants take some time to work. Okay, so maybe weeks, maybe even a month or two or more for full effect. So that's an important thing to relay the message, so patients don't take the medication for 3 days. Oh, this is making me feel a little funny, and then they stop taking it because their depression isn't any better either. So okay, important education point there. With SSRIs, that drug selection is typically going to be based upon adverse effect profile, provider preference, and possibly even maybe some pharmacokinetics and drug interaction risks. SSRIs are going to be the first line antidepressant typically. From a class standpoint, and fluoxetine is obviously included in there, GI adverse effects can happen, changes in sleep, sexual impairment, sexual dysfunction can happen with the use of SSRIs, so important to pay attention to that and ask about that. And then, of course, serotonin syndrome as well. So those are kind of some of the major thing. Serotonin syndrome being less frequent. I mean, it's a rare adverse effect. Along with one other one I wanted to mention was hyponatremia. That's definitely a good one that has come up on pharmacy board exams, pharmacology exams throughout my career. SSRIs are associated with hyponatremia. That's SIADH, syndrome of inappropriate antidiuretic hormone. So if you see a patient with low sodium levels, definitely don't hesitate to take a peek and rule out fluoxetine as a potential contributing factor there. Let's talk specifically about fluoxetine in regards to the adverse effect profile and a couple of clinical quirks. So fluoxetine tends to be the most activating, or one of the most activating SSRIs. So if you got a patient that's really, really lethargic, sedated, and that's the way they feel with their depression, fluoxetine may be a little bit more activating. We generally tend to dose this medication earlier in the day because of that activating profile, just to make sure we're not causing or contributing to any insomnia issues there. Another clinical quirk with fluoxetine, it has one of the longer half-lives compared to other SSRIs. So, potentially good things with a longer half-life include missed doses or late doses may not lead to serotonin withdrawal or SSRI withdrawal symptoms as quickly because that drug is kind of lingering in the bloodstream. It may also be a little bit easier to taper off a medication that has a longer half-life as well there. Fluoxetine, along with, I guess, sertraline, I'd include that, generally have the best safety record with regard to pregnancy if an SSRI is necessary there. So those have historically had the best evidence. And then just wanted to kind of point out, in association with that longer half-life, tapering, discontinuation syndrome can certainly happen, and wanted to remind you of a couple of the kind of discontinuation withdrawal symptoms regarding SSRIs. So GI upset, insomnia, anxiety, and flu-like symptoms can certainly happen with abrupt withdrawal of antidepressants like SSRIs. All right, moving on to the last drug today. It is Triamcinolone. Brand name is Aristocort, and this is a topical corticosteroid, and it reduces inflammation by slowing activity of inflammatory mediators like histamine, kinins, and prostaglandins. So in most situations, Triamcinolone is going to be used I'm discussing the topical use of Triamcinolone here, but when using it topically, it can cause some effects. So skin thinning, enlarged blood vessels, and then if we use large amounts over large amounts of areas, we do have increasing risks for systemic steroid absorption. Okay, now it's not incredibly common. Most patients are going to only use this for small areas, for dermatitis, things of that nature. Maybe psoriasis outbreaks. But again, those systemic corticosteroid adverse effects are possible. So, hyperglycemia, HPA suppression, those type of adverse effects. Again, not incredibly rare, not incredibly common in most of the situations where I see Triamcinolone utilized. But it certainly is something to be aware of if you got a patient that's requesting, excessive amounts, frequent refills, for example, something to maybe pay a little bit more attention to. In patients, with dermatitis, with psoriasis, whatever we're using that steroid for, in milder disease, typically we're going to use a lower potency topical steroid. Triamcinolone is probably considered in the moderate to higher potency. So in lower potency, you're going to look at like hydrocortisone is a fairly low potent example. Again, this can vary based upon percentages and concentrations and things of that nature. But whether we select a low versus moderate or high intensity corticosteroid, topical corticosteroid, depends upon the disease severity as well as probably what's already been tried. If we've tried a low potency and it doesn't seem to be cutting it, that's something to kind of be aware of and may kind of guide clinical decision making. So I did want to list out a few examples here and associate Triamcinolone with this. So lowest potency, hydrocortisone, brand name cortisone there, and then increasing potency, we've got fluoxetine, brand name Lidex, betamethasone probably falls in that category as well. Brand name there is Diproline. And then we've kind of got, moderate high intensity. We've got Triamcinolone. And then we've got more potent, kind of common topical corticosteroid is clobetasol, which is brand name Clobivate there. So, again, kind of some examples there with kind of increasing potency. I will say there is a couple of variations on betamethasone. Valerate tends to be less potent. Dipropionate tends to be more potent. But again, just kind of wanted to lay that out. As far as drug interactions go, typically with topical corticosteroids, it's not something I worry about too much. So definitely something of not high concern generally with regards to, use of small amounts of topical corticosteroids. All right, well, that's going to wrap up the podcast for today. Hopefully you picked up a few practice pearls. Thank you so much for listening. Go to reallifepharmacology.com, subscribe, get your top 200 drug list absolutely for free. It's a 31-page PDF where I highlight some of the most important clinical pearls, things you're going to be tested on. Absolute no-brainer to have. Simply an email will get you access to that. Please support the sponsor, meded101.com/store. Lots of resources there, books, study materials, growing list of resources that can definitely help you be better at pharmacy, learn pharmacology, maybe in a little bit easier way than you've typically been taught. So go check that out, meded101.com/store. Also, if you got any comments, questions, suggestions, don't hesitate to reach out to me, mededucation101@gmail.com, or you can connect with me on LinkedIn as well. Eric Christensen, PharmD, BCBS, BCGP. Thank you so much for listening. Take care, and I hope you have a great rest of your day.